Hi, everyone. So glad that you could join us. It is exactly the top of the hour, but I think we'll give it about 60 seconds for people to trickle in. And today's topic is the Medicare Physician Fee Schedule, Final Rule 2026. So some exciting things to talk about. So I'll give it just a little bit less than a minute, and then we will kick off. Okay, we're going to get started. Once again, thanks so much for joining us. It's been a fun summer to fall to get our Medicare Physician Fee Schedule final rule out. And I know everybody's excited, and there's been a lot of talk, and probably a lot of you know and have read about some of this information, but we're just going to go over it, have opportunity for questions. The Q&A is live, and if you have questions as we go through, my colleague Leah Harlan is here, and she will answer some of those as we go along. I'm going to go through the final rule, and then you're going to get to Ben's going to speak to us a little bit, and then we'll have some live Q&A at the very end. So we aren't just going to talk about the updates. We're going to talk about readiness too, because anytime there's coding changes, there's a lot more to think about than how's it going to affect us financially. While that's always very important, there's more to it than that. So we are going to discuss some of that readiness that we all need to be prepped for come January 1. And by the way, the HOPS final rule is not out yet, unless it dropped in the last 20 minutes. So we're not going to talk about it in depth today. We're going to talk a little bit about HOPS because we have to, because of the changes in the Medicare Physician Fee Schedule. But this is focused on freestanding centers and the physician payment in the hospital outpatient setting. So that's what we're going to talk about. The end-stage renal disease final rule did drop last night, so it's very likely that that HOPS rule may come out today. They're notorious for dropping these on Fridays at 5 o'clock and right before a holiday weekend too, right? So just a few disclaimers. As always, every practice is unique. It is the physician and the practice's job to do their due diligence, understand coding, compliance, utilization, and all of that fun stuff. And of course, we are using AMA CPT coding in here, and we do acknowledge that. So when you look at the final rule, some of the big updates that we're going to talk about are the external beam treatment delivery codes. That's like the hot topic, as well as the image guidance update. But we do have some other things to touch on, and that is a complete change in the surface treatment. So we'll talk about those updates. Physician supervision and telehealth that has been trickling on since COVID. And we'll talk about some of the finalizations of those things, which is really good for our industry. Work RVUs, some practice expense RVUs, and of course, the conversion factor. The changes in the treatment codes. So this is where everything has gotten really interesting and that people have been so excited and having to make all of these decisions. So treatment codes under the Medicare Physician Fee Schedule as of this rule, are valued based up on ops rates. And that is very different. That is not what we've had in the past. We knew that these treatment these treatment codes were going to change because in the fall of 24, it was time for those codes to be reevaluated by the RUC and the AMA. And when they looked at everything, they said, okay, it is time to make some changes here. So those changes have gone into effect. Our G codes that we've been using since 2015. It's a very, very long time for us to be using those codes. Notice it's the 10-year, right? Like that's when these codes come up for a new look and valuation. So no more G codes in the freestanding center. And all of this is focusing on ways to make things congruent between the hospital and the freestanding centers. We will report 77402, 07, and 12 for our daily treatment deliveries. So that entails a lot of things. There are no separate codes for IMRT. We fought long and hard for IMRT codes many years ago, and we are now seeing that they are deleted. So the 77385 and the 77386 have been deleted. And all treatment codes will include the technical side of image guidance, which I know has really gotten a lot of people in excitement phase over that, right? So that is one of the things that is caused some people some heartburn. But we always have to look at the big picture, and that's what I continue to remind people at all times. Don't just hang your hat on the one thing that you feel like is absolutely the most important. So when we look at our image guidance codes, lots of changes here. Our 77014, our CT guidance, has been deleted, and that was what most people were using for their cone beam CT. And, you know, that code, we were lucky to keep it as long as we did, because those of you that are as old as I am, remember we used to bill that code on the technical side when we did simulations many, many years ago. And we got lucky and we got to keep it when cone beam came around, and it got valued really well. So, you know, I don't think we can yell too loud about the fact that we had some goodness there for a long time. Our HCPCS codes that we were using for image guidance through the G codes and the G6017, along with that 77014, are deleted. So those are gone come January 1. We will report, since the technical side of the image guidance is inside the treatment delivery codes, we will be reporting 77387 with a 26 modifier for any and all types of image guidance, service guidance, whatever methodology we are using. This is what the physicians will use, 26 modifier for the professional component of image guidance going forward. Technical, packaged in there, professional, still billable. So, and you know, regardless of the modifier, the RVUs are the same because it's only valued for professional side of things. And our port films are no longer reimbursed. So this is just a nice side-by-side comparison that we've done here. And you guys will have this document sent out to you. And it's just the nice summary from the AMA that shows you which codes are deleted. It shows you what the long descriptor is for the 77402, 07, and 12. And it's so important that you read the long descriptor. It's always been important because it will typically answer your question that you may have on what you're doing, what treatment delivery, the work that goes into it, where it lies. So never more important probably than today to read that description very, very well on particularly the 407 and the 412, but also the 402. I mean, because we are going to have examples where we will be using simple, intermediate, and complex going forward. Just shows the 8.5 and 8.6 deleted, the 8.7 being for the pro side, the 014 once again deleted in our port films. So you will have that handout. So if the print's too tiny, you will get to see that. Moving right along here, when you look at the freestanding center and you're looking at a comparison as much as you could, right? Like it's running the apples to apples comparison from old treatment delivery codes to January 1 codes is really, really difficult because you can't even factor in by diagnosis because we treat different patients different ways. And that's the whole point, right? So for our 2D treatments, we're going to fall in the 402, where before we had that big range of 603 to 614. 3D are going to be our 07 and our 12. IMRT, same thing. All of our image guidance, surface guidance, whatever we're doing is that 77387. So just a good reminder there of how this is going to work. So looking at our treatment delivery codes and rates, once again, this is now we did have Medicare, when they put out the Medicare physician fee schedule, they gave us a set of rates. And then on November 3rd, they updated. So that confused folks, but it does happen occasionally. People make mistakes, updates get made. Sometimes we have updates periodically through the middle of the year because some little RVU or something gets tweaked. So remember that these treatment code rates are about non-stereotactic daily treatment delivery. So stereotactic, not affected by these. RO2, single electron, multiple electron fields, or 2D photons. And right there in our descriptor, it clearly says, including image guidance when performed. And this is a technical code, so it's talking about the technical portion of image guidance. Pays right at $80. These are national averages. Your numbers, depending on your state and your location, may be a little bit higher, a little bit lower. 77407s are level 2. Single isocenter, example 3D or IMRT, photons, including image guidance. So theoretically, you could have a single isocenter IMRT treatment that is a level 2 77407. Now that's a real mind shift for radiation therapists capturing codes, right? So make sure you're doing some really good education with your folks, and we'll talk a little bit more about other adjustments you need to make. Looking at 77412 level 3, we're right at $391, and if you compare the level 2 to level 3, you see we've got a $70 differential there. Read this one carefully. Multiple isocenters with photon therapy. Could be 2D, 3D, or IMRT, doesn't matter. And then it says, or a single isocenter photon, 3D or IMRT, with active motion management. Or total skin, or mixed electron photon fields, all including image guidance. So they tried to get everything they could possibly get in there, but you have to know that all those ors are in there. So you have to really pay quite a bit of attention to the various options that could come up. There's our image guidance rate for the professional component only, $36.74. And this is where we're at, right? Like people want to only look at the comparison of what they were getting for one of their other image guidance codes on the technical side. But in the freestanding, you got to remember, you are still getting a piece of it, but it's the professional piece of it. This next document I absolutely love, and I know it probably may be too small for you to read, but we are providing that to you also. And it's really good for your staff because it gives you a start. Are we doing electrons, mixed electron photons, or photons? And then you can just go through the decision tree to see where you land. So if we're looking at photons, multiple isocenter, automatically you go to 412, level 3. If you are a single isocenter and you're a 3D or IMRT and you have active motion management, you fall right into level 3. So just a really good quick decision tree to share with your staff to make sure that everybody understands the difference in these codes. And then you can look over here and it gives you nice description. I don't want to, not point out that we had some other notable rate updates for 26 that a lot of people, some of these seems to be falling off the radar because everybody is so focused on their treatment delivery and missing out on some of the technical image guidance with it getting packaged. Our IMRT planning went up 10%, right? Our continuing physics that we bill every week, 5%. Our special medical physics consults, 5%. Our stereotactic delivery, 4%. And our weekly treatment management. I got a bug flying through here. Our weekly treatment management also went up. So there are, there's plenty that we have going on here that is good for our departments and for our staff. So notable increases there. Looking at surface guidance, really this is just a complete overhaul also. It seems like it was the year for us to have overhauls and potentially not a bad thing. So our 77401 completely deleted. We now have a single CPT code for SIM and planning, new treatment codes, and image guidance being able on our surface treatment to get reported once per course. And these are the whole subset of new codes. They range from 436 to 439. And the initial one is our superficial or orthovoltage treatment planning and SIM. So that tells you a lot, again, to read that descriptor, that everything is part and parcel of that 436. We're not going to be billing our SIM or our treatment planning separately. Our 437 covers our superficial, and our 438 covers our orthovoltage. And then we get a one-time surface guidance, radiation therapy image guidance for the ultrasound once per course. And it tells you that very clearly in the descriptor. Physician supervision, that has been on the radar since COVID, whenever it was relaxed. And I always have to remind people, this isn't about just radiation therapy. These changes aren't just about us. From the direct supervision standpoint, that is about all specialties, right? And what they've done is they researched and watched and saw that having real-time video and audio did not pose hazards. There was not safety concerns. So that supervision in the freestanding center is now done. It includes all the language. We have to make sure it's real-time video and audio. So that is good news for us. That is great news that for our more rural centers that have, you can't saddle a physician there 40, however many hours a week every day when they're treating 15 or 20 patients, because it makes it not viable. So I really do love this for our rural centers that are providing a great need for patients to be able to be treated locally. It's good. We also have the elimination of the provisional status for telehealth CPT codes. The 77427 is now on the permanent telehealth list. It was on provisional forever. Once again, requires audio, use of video. It has to be both. And you do need to put a modifier on there and make sure that you're doing that. That is very important, that somehow you relay that information from whenever you capture that code in ARIA or Mosaic or RayStation, wherever you're capturing that you actually make sure that your billing people know the method of that 427 if it was done via telehealth, so that can get on the claim appropriately. The other on treatment visit codes, the stereotactic and the short course still require in person. So this is only for 77427. So there was reduction in the RV, there was our work RVU updates that did occur. And when you look at the work RVU updates, there was a reduction of 2.5%, right? It applies to non-time-based services, so we're not talking about our E&Ms. Those remain steady, tiny increase. So our E&Ms on our physician side, we don't have to worry about that, which is good. The other exclusions are the ones on the telehealth list and the new codes. But with a work RVU reduction, physicians that are paid according to their RVUs do need to address this with their management, because there was a reduction there and it will impact them financially, right? And we have to remember, so if some codes get higher, some get lower, how does all that work? That's about this balanced budget, right? That's what CMS and Medicare has to do. We have so much money coming in, so much going out. So there's always this give and take. And that is what we see here, right? Treatment delivery codes, this goes up, this goes down, work RVUs goes up, down, the conversion factor, which we're going to talk about, going up. But we do suggest that physicians, do a good look on their RVUs and do a comparison there, so they have an idea of what's going to happen there. And this is really about the MEI. And the MEI is the Medicare Efficiency Index. And what they're getting at is, you people have been doing this a long time. You should be getting more efficient at it. Your work should be less because you're more efficient with today's technology. So, they probably do have a decent argument there. The conversion factor, this is the first year that we've ever really had a two-prong conversion factor. So if you are in an advanced payment model, then you're going to have a conversion factor of 33.5675. If you're not in an advanced payment model, then your conversion factor is going to be $33.4009. So that's interesting, right? So one physician's payment in the same location may be less than another's, not by much, but there is going to be pennies on the dollar there. But both of those are an increase over the conversion factor of 25, right? So there again, it's that balanced budget thing. So we take some money away in the RVUs, but you're getting an increase in the work RVUs only, but you're getting an increase in your conversion factor. And all of those are what make up your payment, right? The conversion factor, the work RVU, practice expense, all of that. So that's always interesting. This is where things have really gotten interesting, and it's really a correction of the disparity between the hospital outpatient payment, which for years we have seen go up, 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 maybe just 2% a year, but all of those hospital technical charges up, 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 up when we would get hits under the Medicare physician fee schedule. And so this is where Medicare is saying, we need to forget having this site of service differential, and we're going to align some things with HOPS payment. And that's exactly what they did with our new treatment delivery codes. They went, okay, HOPS has had those same codes, been using them forever. Let's make an alignment between the payment for the HOPS treatment delivery and the payment for the Medicare physician fee schedule. So that's how they set those rates, which in the long run should be good for us. We did have, that's where we got the updated practice expense factors. Added some direct practice expense factors for those new codes. They updated the LINAC and the water chiller cost. You know, those numbers were very old. And it takes a lot of work on our society's part of Astro and Acro to get people to provide what their costs are for such things as LINACs, so that that can be valued in these codes. They updated the superficial system cost, which they had to do because of the new codes. And they actually updated the 55874, and it's paying more because they updated what the prostate spacer kit cost. So there's all kinds of changes that went into that practice expense for this year, or this coming year. So we do have links to both the fact sheets, and you guys are going to get this PowerPoint as well as the other documents that I touched on for your review. And now we have to talk about the readiness. So it's not just, okay, we got to prepare and be able to make sure our coding is what it needs to be and that our staff is trained, but we have to think about OS, fee schedules, and other things that we're going to touch on right quick. From the EHR standpoint, the timeline to do this is now, right? We know what the final rule says, so now's the time. Educate your staff, get into ARIA, update your CPT codes in your data admin, update your activity code sets, obviously not to take effect until January 1, but to get prepared for it. If you're in Mosaic, update your code library, update your order sets. If you're in Epic, update your charge master because your codes are different, particularly for treatment delivery and the superficial. So starting to look at your EHR now is very important. Prior auths, right? So we always tell everybody, you know, at the beginning of the year, no matter what is happening, review all of your authorizations. Some payers make you get a brand new auth. In fact, a lot of them, if not all of them, come January 1 anyway. So you have to make sure that you're on treat. If they're still going to be treated in 26, add those to get those updated with the new codes. Most Medicare Advantage plans expire on 12/31, so they will need a new auth. Check any that are going to expire. Check with your commercial plans and really keep a list of your payers narrowed down by types to really look at the requirements on the CPT codes. I hate to say it, but I doubt if there's a Medicaid in the United States that's going to be ready to accept those new codes. Right? Like, we can hope that they are, but that chance is pretty slim for, I know, a lot of the Medicaid. So there's going to have to be a lot of diligence on the RCM side through December, through January, through February to make sure that we have some changeovers going appropriately, and that if they're not ready for the new codes, that we could get the old codes out very quickly. So you're probably going to have the ability to capture both for a while. Looking at our fee schedule updates, you know, this is the part that scares me, right? Looking at your contracts is another thing that has to happen now, because what does that contract say? Will they be ready to take the new codes? But what does the contract say? Does a fee need to be negotiated? Do you need to reach out now about that fee schedule? You know, if you have one that doesn't have those codes, but maybe it does have those codes, but it's based on a very old rate and not the Medicare rate that we see today, then some renegotiation is going to need to happen. So get on that absolutely today. Start scouring your contracts to see where you're setting. Proton centers, so while their treatment delivery didn't change, though there's a mention of it, right? There's a mention of those proton delivery codes in the freestanding becoming not carrier priced and looking at valuing them, assigning RVUs. Right now, that's not in the mix, but they did get hit losing their technical component of any kind of image guidance or SGRT, right? So there is an initiative on behalf of NAPT and proton centers to really, you know, look at your MAC, look at your commercials, reaching out to your MAC saying, hey, this happened on the photon side, but it's affecting us negatively because it's not packaged. It's just those codes have went away. The codes got deleted, but they're not included. So that is something that as an industry, everybody is really looking at right now too. I am going to stop sharing and turn this over to Ben to speak to you a little bit more.
Great. Thank you so much, Sally. That was a really excellent overview. So just pull up my slides here. So yeah, thank you again, everyone, for joining. And thanks again to Sally and also Leah, who's working diligently as well, answering the questions that are coming up. So please, as questions come into your mind, please post them into the Q&A section and we'll continue to answer those. So I'm going to be focusing just a few minutes on one specific area of the complex radiation therapy delivery code, the 77412, which is active motion management. So the use of active motion management during this single ISO photon deliveries. So I'm going to actually start off with a bold statement. At least if I'd have made this statement a year ago, I think it would have been considered bold, even though there's a lot of clinical evidence around surface guidance, which is a form of active motion management. But I think hearing what we've just seen over the last few weeks and with Sally's update, I think it's becoming more clear to see now that now is really the time to consider having SGRT on every LINAC. There's clearly some clinical benefits or lots of clinical benefits for all of your patients, whether you're treating anywhere from head to toe. But now there's also these additional incentives when it comes to opportunities for billing at these higher complex codes. So when it comes to surface-guided radiation therapy at Vision RT, we have our flagship product, Align RT, which is intended for assisting with patient setup and monitoring throughout the radiotherapy session. So therefore providing active motion management throughout the therapy course. So I suspect many of you are familiar with this technology. Hopefully many of you are using this daily for all your patients. But if not, essentially this is a ceiling mounted optical camera system that's actively reconstructing the patient's position in real time. So with Align RT, that means around 25 times every single second, we're getting an update on the patient's position throughout treatment delivery. And this clearly provides a very accurate way of monitoring the patient's position throughout treatment. And if they're to move during delivery, there's automation with the treatment systems that allows the beam to automatically turn off as soon as that movement is detected. And there's one feature called postural video. I'll briefly mention on the next slide here. But this is a feature that's unique to Align RT, and it provides a real-time video feed of the patient with a pink outline showing where the patient's position should be based on the treatment plan or previous radiographic imaging. So the question you may be asking, in addition to using SGRT on every LINAC for every patient, is why Align RT? So I just wanted to put together a few little pieces of data that we have for this flagship product. So many of you will have been using our technology for hopefully many years now. In fact, Vision RT was the inventor of the SGRT space close to 25 years ago now. And in global clinical use, we have experience of tens to hundreds of thousands of patients undergoing radiotherapy with Align RT guidance every single day. So that's a huge amount of patients. And there's one thing that really I think I start taking for granted, and that's this emblem shown in the top right here. But what this is telling us that year on year, we are being used, or the Align RT solution is being used in 24 of the 25 best hospitals for cancer in the United States. So I think this is real testament to the quality and the value that Align RT brings. And it's really great that we're trusted at these top centers. So I mentioned postural video on the previous slide, that video live feed of the patient. There's lots of clinical data now showing that just using standard SGRT without postural video, there's some real efficiency gains to be had. So compared to more traditional tattoos and lasers approaches, there's about a 22% time saving per fraction using SGRT. Now, in addition to that 22% time saving, when you use postural video, which gives you a good overview of the patient's posture during setup and also monitoring throughout treatment, there's an additional time saving, depending on the studies you look at, between about 25 to 40 seconds per fraction as well. So this is a great tool for efficiency. And then I'll discuss over the next couple of slides how surface guidance and using some tools within Align RT can really help facilitate your reporting when it comes to taking advantage and using these new complex codes. So more efficiently being able to provide documentation of the active motion management. Vision RT aims to be truly vendor agnostic when it comes to treatment systems. So we have compatibility with all the major LINAC vendors. That includes, as I mentioned before, things like automated beam hold. So as soon as the patient moves out of position, we can automatically send a signal for the beam to be held until they return back to the correct location. And this means that Vision RT and Align RT can be used in these multi-vendor environments. So we try and remain completely agnostic and available to add this clinical value to all centers. And then finally, it becomes increasingly more important now that the value of SGRT, both the clinical value and now these opportunities from a reimbursement standpoint, that it works with every single patient. And this means not just the complexity of the plan, if there's any non-coplanar deliveries, for example, but every single patient with respect to varying skin tones. So the data has been published showing that Align RT works reliably with a high level of accuracy across all different patient skin tones and through all different treatment deliveries as well. So that's really important. And in addition, you need the system to be reliable. So our target for uptime with Align RT is 99%. And in order to help achieve this, we have a very large team around the world, but in the US as well, that are 100% dedicated to SGRT. So their only role is to support surface guidance and Vision RT's products in that space. So both on the clinical application side and also with respect to the service engineers. So looking in a little bit deeper into how Align RT has tools to help facilitate financial reporting. I stole this quote from SGRT super user Mike Torhammer. I really like it. It's, if you didn't document it, you didn't do it, as says every auditor ever. So I think there's obviously a lot of element of truth to this. So your patients are getting the benefits of active motion monitoring, active motion management with Align RT. So let's now document that we did this for reimbursement purposes. So Align RT has an automated reporting feature so that every treatment monitoring session you have using Align RT, there's a configurable report that can be generated or is generated for every patient. So as I mentioned, there's a lot of configuration that you can set up on your end to provide the data you need. It includes things like a statement for that treatment monitoring session, which could be valuable for documentation purposes. And then information about the patient's position and just proof that you were actively tracking that patient in the appropriate location. So this is available with all versions of AlignRT. But when it comes to more efficiently being able to process this data and have it in a useful manner for submitting for billing purposes, there's a new tool that we released in the last few months from VisionRT that's called OAS Reports module. So the intent of OAS Reports module is to take this report that's generated by AlignRT and that is stored to the local workstation with AlignRT, and then take that automatically, convert it into DICOM format, and push it directly into your OAS, whether that's ARIA or Mosaic. So the OAS Reports module sits on the workstation with your AlignRT system, and then whenever a patient's monitoring session with AlignRT closes, it automatically, without any additional input from the user, it automatically takes that report, converts it into DICOM, and then pushes it over to ARIA or Mosaic. Just to show an example of what this looks like with ARIA, we are able to push across and then insert into the correct patient's treatment timeline is shown here, but also available in offline review. We have the end of treatment report and any screenshots that you capture using AlignRT throughout the monitoring session. So for example, if you have a breath hold patient and you want to document that the patient is in the correct breath hold position before treatment starts, you can take a screenshot at that instance before you start treatment delivery, and that will show up in the appropriate time frame chronologically relative to the beam on. So this tool is available, the OAS Reports module, and the goal here is to help really further drive value such that your clinical users are having to focus less on these formerly manual tasks of sending data across and importing it into the OAS, but really relying more now on this module to do it automatically. And as we can see here, a quote from another of our super users, Adi Robinson at Advent Health, who's been using this tool for a while now. Really, it does what it says. It really provides the opportunity to never miss sending across an SGRT report. There's no staff that needs to actively take the time to send this across. And it also places it in a place where if you configure it in such a way, the physician can review and approve these images that come across from AlignRT. So with that, this was just intended as a brief review of how AlignRT as an active motion management solution can be used to help facilitate both efficiency within your clinic, additional clinical benefits for your patients, but also help support the opportunities with this new 77412 code. So with that, I'm going to hand back to our review of any questions that may have been popping up on the Q&A and invite you, if you do have any others, to please keep posting them. But now is probably a good time, Sally, if you've been reviewing these questions, to see if there's any that haven't been answered yet by text, to see if there's any that would be good to answer.
I think Leah's got a couple she's going to jump in on.
I do. Can everybody hear me?
Yes, thank you.
Perfect. Okay, the first question that I wanted to say for the live Q&A was HDR brachytherapy, iridium 192, when used with skin applicators. Is that 77436? That would not be. That will still be your HDR brachytherapy codes for skin treatment that you have been using. The 7743 codes, those are all meant for our superficial treatment done with external beam radiation. And then next up we've got is 77436 built together with 77437 each fraction. Again, these are the skin superficial treatment codes. And no, the 77436 for all of your planning and simulation work, that would be billed one time when you complete the planning work.
Ben, do you want to catch that one about beam control?
Yeah, so there was one question which maybe you're better situated to answer, Sally, which is about, does active motion management infer that you need to have beam control on, so automated beam hold, I suppose, with active motion management?
So basically the question is all continued motion management during treatment.
Yeah, and specifically if that requires that you have the automated beam hold capabilities, or if you could just review that data and manually hold the beam if you see the patient has moved. So whether or not you need that automated beam hold.
So that's really about equipment then versus,
Yes.
yeah. So I would say active motion management better served automatically, but I would consider the fact that the reimbursement is higher, that it's about more technology, more expense. So I would say during treatment, is a payer going to know whether your equipment's doing it or you're doing it? But the ideal scenario is active motion management. Active motion management, meaning that's all our descriptor gives us, right? Active motion management would infer that that's during treatment. And I do want to jump in, and I agree when I talked about the MEI index, I do agree with you. When I said that somebody in the Q&A disagreed with me on how more efficient we should be, and we should be with our processes. But I do agree with you, the administrative burden of authorizations is out of control and unrealistic. And I think it's going to be very interesting to see how payers address these new CPT codes for treatment delivery. The hope is it kind of goes away a bit, right? Because what authorization person is going to, or person who's going to be even reviewing medical records, be able to differentiate ISO centers, right? Like that's a very clinical thing. So that's going to be very interesting as that goes through. The prostate questions come up a million times, right? That is not for me or anybody that's actually on this panel right now to make the decision. Only radiation oncologists can substantiate and determine what is best for their patients and supply that medical necessity. Not for me to do. And that goes back to our auth question, right? Like, are payers going to look at this and try to cookie cutter us into certain codes based on diagnosis? They really can't, right? Because of the multiple ISA centers and the different scenarios within that level 3 code. So it's going to be very, very interesting. Physicians do need to sign if they're billing the 77387 with the 26 modifier. They do have to sign those documents. And one of them asked here, Ben, how do the physicians sign? And I don't know, maybe you talked about that.
Yeah, absolutely. With that new OAS reports module, there's the ability to request physician approval through that tool. So as it comes into offline review, like it would for your other radiographic images, this will show up in the physician's list to approve that a line RT report or screenshot, just like you would for any CBCT or otherwise. So I think that's probably the best way to do that.
Okay. Can we bill a simple simulation on the first treatment for 3D? There again, physician ordered, medical necessity, 77280 being all ports. imaged and approved prior to treatment, then, you know, yes, but you got to check all those boxes, right?
There was a question about, I think a user that maybe doesn't have the automated beam hold with their TrueBeam system. So yeah, absolutely, that is available as a capability. For TrueBeam, we have an interface to their MMI. For Elekta, for example, Elekta Response or integrated gating. So yes, I'd recommend just reaching out to either your clinical team or your regional sales manager, and they'll be able to provide more information about what's available. And yeah, just another question, can you sign without the new reporting? Yeah, I think that will be more of a manual process. I think that means if you don't have the OAS reports module that automatically transfers the data across to the OAS, I think you would then manually need to transfer that PDF report that's created from AlignRT, manually upload it to the patient's document list, and then approve it through there. So there are ways to do that, but certainly more work. And maybe this is a new one for you, Sally, maybe about expectations of the distribution of the 407 versus the 4412.
Yeah, for a
SGRT.
site with SGR capability, what is the expected distribution of 407 and 412? Oh, Leah wants to answer it. You get in there, girl.
I will. So we did get some rates. AMA, the RUT committee, when they first proposed to make all of these changes back toward the end of 2024, they issued some percentages for the 3 daily treatment codes. CMS, they updated those in the final rule for what they're expecting to see. But keep in mind that those are budgetary numbers. The percentages that they're doing is simply for budgetary purposes because, again, they have to balance that budget. They are not something that you have to make sure you hit exactly those marks. It's nothing like that. We want to make sure everybody understands it's just budgetary. When the RUT committee made their recommendation, it was 5% level 1, 50% level 2, and 45% level 3. CMS came back and updated those to 10% level 1, 55% level 2, and 35% level 3.
And I would add in there, definitely, that's what they are. They're budgetary. They had to say, this is what we expect. In radiation oncology, have we ever, since 1985, used simple, intermediate, and complex of any distribution of codes evenly? Never. And the reason we don't is because of our technology. And we're treating cancer patients, right? And there really isn't anybody to police that. Now, if you become a statistical outlier, what happens? Eventually you get looked at, right? Like that is the reality of Medicare. But as far as any other folks policing it, no. Payers, Medicare does due diligence, right? They look at where people fall, but just like IMRT, right? When IMRT came out, everybody was cautioned, don't use it for everything. You know, if you looked at this year, how many of your patients are IMRT? You know, you're probably in that 70% range or something. So that just is what it is. But those numbers that you keep hearing were in the rule, and they're about budgetary purposes.
Sally, do you want me to take that one?
Sure.
Okay. The question, if you align with SGRT and no image guidance, is 7738726 valid? Yes, that is now included with 77387. They have put all IGRT and SGRT into one code bucket. So yes.
Just make sure ordered, documented, signed.
Yes.
And that was the last of the questions.
Yeah, I think that was great. Thank you so much again, Sally and Leah, for supporting this and running us through all these new opportunities we have. It's a challenging area, but I think you've done a great job of really making it very clear to everybody. So thank you again. And as we've seen in the chat, these slides, I think they've already been posted, so they're available to anybody who wants to review them. And of course, feel free to reach out to any of us if you have any follow-up questions on this topic. And hopefully we'll hear about the HOPS announcement before long as well, and maybe even be back to talk through that as well. So yeah,
We're
thank you
still
again.
waiting. It's not there yet.
It's not there yet. Okay.
I keep refreshing, but it's not there yet.
Not there yet. We'll wait patiently, but hopefully not too much longer. So yeah, thank you again, and thank you all for attending. Take care.
Have a good day.
Thank you. Bye.